Good morning, everybody. Thank you so much for inviting us here today to talk with you all. As Jared said, my name is Dr. Whitney Herge. I'm one of the pediatric psychologists primarily on the Dallas campus, and this is my colleague, Dr. Gale, another pediatric psychologist who's based primarily here on the Frisco campus. And we are here to talk to you today about our study, the assessment of psychological responses to the COVID-19 pandemic. We have nothing to disclose, but we have many people to thank. So this includes Dr. Sakato, Dr. Stapleton, our psychology fellow, Kylie Papineau and Shelby Surza, both from the research department, Dr. Joe, our biostatistician, as well as the entire Scottish Rite Red Cap team and communications team, without whom this study would not have been possible. So the purpose of our study is to evaluate the stress and coping responses of individuals in response to the COVID-19 pandemic. So the reasons that this is important have been alluded to many times already, but specifically previous research that's examined the stress responses of individuals in the face of the 2003 SARS outbreak, the 2009 H1N1 outbreak, as well as the 2013 Ebola outbreaks, have all shown that individuals experience high levels of stress, including anxiety symptoms, depression symptoms, post-traumatic stress symptoms, and even feelings of helplessness, self-blame, and grief. And that these symptoms are very long-lasting. So we recruited participants who were 18 years of age or older from a variety of different groups. So this included both current and former hospital patients, patient family members, hospital staff and volunteers, as well as community members at large. In thinking about our study design, our study is intended to be a prospective longitudinal 3-wave design. So we're hoping to collect data from participants at 3 time points across approximately 9 months total. Wave 1 of our study was initiated in May 2020 and is actually still open now, so we are still continuing to collect data from participants. Wave 2, participants are going to be completing assessments approximately 12 weeks after the point at which they first completed our assessment for Wave 1, and then we're also going to be following up with participants approximately 6 months after Wave 2. Thinking about our participant recruitment, we used some novel methods of recruitment for this study. So to contact patients and patient families, we received both IRB approval as well as RAP, so the Research Advisory Panel at Scottish Rite, to utilize Twilio, which is a HIPAA-compliant messaging service to contact patients and families. And we also utilize social media, so the Scottish Rite Facebook, Instagram, and Twitter pages to try to reach those patients and patient family members. To contact hospital staff and volunteers, we used our internal coronavirus update emails as well as the Scribbles emails. And then to reach the community, again, we were relying on social media as well as more targeted community outreach, so sending out emails and phone calls, and also reaching out to the media. So we had the pleasure of speaking with Dee, CEO of Healthcare recently, and we were really grateful for that opportunity. For Wave 2 and 3, we are intending to contact participants utilizing either text message or email based on their stated preference at Wave 1.
All right, so we just want to go over real quick the kind of measures that we used, and we tried to choose empirically supported and well-validated measures that some of our other psychology colleagues at various other institutions are using so that we can compare our data with theirs. But first we started out with some basic demographic information, age, what clinic or service they use at Scottish Rite, race and ethnicity, gender identity, education, income. And we also asked very specifically if they are a healthcare employee and how that has impacted them, and also where they're getting their news, because we found in previous literature, in the psychology literature, that where you get your news and how much news you're consuming can affect the way that you experience stressful situations. So we asked if it was TV, radio, print, online, or social media, and then how many hours in the past 2 weeks they've been consuming news. And we're going to take a look at that when we come to the data analysis portion. We also asked about the presence of at-risk health symptoms, such as asthma or diabetes, whether or not they have had exposure to COVID-19 or suspected that they have, and if they have symptoms currently while they're doing our survey. And then when we look to assess stress, we consulted with Betty Lai from Boston College, and we used one of her measures that's been modified for COVID-19, the COVID-19 stressors scale, and it's an 11-item self-report measure with ratings of not concerned, somewhat concerned, and very concerned. and that's pretty self-explanatory. And then we looked at the PTSD checklist, which is another very well-supported, empirically validated measure in the psychology world. There's 20 items. You can see that there's a total severity score, there's a cutoff score of 33 that you can use to diagnose probable PTSD, even though that's not really what we're looking for. What we're looking for is some of the symptoms that might be most kind of distressing for people. So things like intrusive thoughts, avoiding memories of stressful situations, or disturbing dreams. And again, this measure is psychometrically sound and is used very widely in psychology so that we have some data that will transfer to other institutions. And then we use the brief COPE to examine coping behaviors. And this scale really looks at different ways of coping. Some of the statements that people respond to are, I've been saying to myself this isn't real, or I've been using alcohol or other drugs to make myself feel better. Or on the more positive side, I've been taking action to make the situation better. And the participants read these statements, and then they give themselves a rating from 0 to 4. The options are listed up on the slide. And again, this measure is psychometrically sound and is used by our other colleagues so we can compare across sites. And then finally, we asked some free response questions. And we asked participants to write as little or as much as they would like. We offered some prompts to help get them going, such as how has the disease impacted you, your family, and your community. And people really have given us a wealth of information that Dr. Herge is going to talk about in a few minutes. Thank you.
All right, so because we are still in our data collection phase, we don't have any results to present to you yet, but we are excited to tell you about what our sample looks like so far and what our data analytic plan includes. So we have had 2,505 participants create a record, meaning that they've opened the survey and they've completed some portion of it. Just under 1,400 participants have completed the entire record, so they've completed the survey all the way through. And of those, 918 participants provided qualitative data, so that last measure that Dr. Gale was just talking about, because that piece was optional. And the vast majority of our participants are English speaking because the survey was also available in Spanish. Looking at our demographics, our mean age of our participants is just under 43, and participants range in age from 18 to 86. Approximately 80% of our sample identifies as cisgender female, 17.5 identify as cisgender male, and the remainder identify as either transgender other, or they preferred not to respond. Thinking about race and ethnicity, approximately 70% of our sample identifies as Caucasian, approximately 13% identify as Hispanic or Latinx, approximately 8.5% identify as Black or African American, and approximately 3% identify as Asian. Looking at our SES status, so approximately 2/3 of our sample have a bachelor's degree or higher, and a similar percentage have a family household income of greater than $75,000. So certainly our sample is skewing somewhat towards the higher SES range, but we do have representation in the other SES levels as well. Now looking at our different groups, because we were sampling from a variety of different groups. Approximately 2/3 of our sample are either parents or legal guardians of Scottish Rite patients. About 13% are individuals who are community members. Approximately 10% are Scottish Rite staff members or other hospital employees. And about 5% are current or former Scottish Rite patients, which makes sense because we are a pediatric institution, and so we wouldn't expect a high number of participants coming from our hospital. As Dr. Gale mentioned, of those participants who are either a patient or the family member of a patient, we did ask them what sort of services they're using at Scottish Rite. Our highest count came from the scoliosis and spine group, followed up by sports medicine and fractures, so thank you, Frisco. And then you can see the breakdown from there. We also asked those particular participants which treatments they're primarily utilizing, and you see that approximately half of our sample is engaged in either observation or symptom monitoring, with about 11% being followed up postoperatively, and about 10% being followed for either casting or bracing. So, what do we plan to do with our data? We actually have a lot that we're really excited about. So of course, we're going to be conducting preliminary analyses. We'll be looking at means and standard deviations and comparing our data to predetermined cutoffs where those exist. So for example, we're going to be looking at participants' responses on that PTSD checklist to determine what percentage of our sample likely meets criteria for PTSD. We'll also be conducting ANOVAs to identify any differences that might exist between our participant groups. So seeing how do family members of patients compare to hospital staff, compared to community members, to see are they reporting different levels of stress or are they utilizing different coping skills. But what we're most enthusiastic about is looking at this data longitudinally, and we intend to do this in a couple of ways. So first, we're going to assess the patterns of trauma response over time to identify unique patterns. So previous trauma literature, especially literature related to disaster exposure, so for example, hurricanes, tends to show that individuals fall into one of a couple of profiles after traumatic exposure. So there are some individuals who we would consider to be chronic experiencers of symptoms, meaning they're reporting high levels of post-traumatic stress over time. There tend to be a larger group of individuals that we consider to be recoverers. So those are individuals who report high symptoms initially, but then those symptoms decline over time. And then there are some individuals who we consider to be in a more resilient group, such that they're showing low levels of post-traumatic stress symptoms over time despite trauma exposure. So this is one of the ways that we're going to be looking at our data over time. But we also intend to be looking at the interrelationships between our data. So for example, we are interested in looking at time 1 COVID stressors, so that's our wave 1 data, and how that's related to post-traumatic stress over time. So at wave 3, approximately 9 months later. And we're going to be looking at coping skills in a variety of different ways. It's possible that coping skills are functioning as mediating variables, meaning that an individual who's experiencing high levels of COVID-related stress, that's going to cause them to use more maladaptive coping skills, which over time will cause them to experience higher levels of post-traumatic stress. That's one way that coping skills might be functioning. But we're also going to look at them as potential moderating variables, which would mean that time 1 COVID-related stress leads to higher levels of trauma symptoms over time, but only in the setting of using more maladaptive coping skills. We don't have any a priori hypotheses about this data yet, just because of the completely unique and novel situation that we're in right now. And then additionally, we're going to be analyzing our qualitative data. So we're currently in an iterative process of code development, meaning that our study team is pulling groups of qualitative responses to develop out which codes we're going to need to try to fully capture the richness of this data. Just to give you a sense, some of the codes that we're using include things like social isolation, financial status, and then specifying either stability or instability, the use of coping skills, either proactive or maladaptive, or even the assessment of government response. So we've had people say that they're either satisfied with the response or unsatisfied. And then we'll also specify, are they unsatisfied because they're perceiving an overreaction or an underreaction? And ultimately, we'll be conducting a thematic analysis on all of this data. Just to wrap up, I wanted to give you a couple of examples of our qualitative data because I think it gives a great insight into how these responses are really spanning the entire gamut of sort of psychological responses in this setting. So on one end of the spectrum, we have people saying things like the following. At first, I was annoyed by what I felt was an overreaction to a respiratory virus that could be nothing more than a cold. Part of me understood the response, but more of me felt it was ridiculous. I honestly still get a laugh at seeing everyone wearing masks, a lot of them incorrectly. I have still had to go into work every day, so I haven't benefited from working from home as others have. I probably feel a little jealous. The best part of this has been being able to take margaritas to go and not having to rush around in the morning to take my son to school. I've been breaking the rules by seeing friends on occasion. That's helped me through the isolating feelings more than anything. I'm hoping this virus will become like the next flu, just one of the seasonal bugs that we see over and over. We've also had some more what we would consider middle of the road responses. So those include things like we're abiding by the rules, keeping distance, wearing masks at stores, supporting the local economy by getting takeout for dinner a couple times a week, and hoping that the numbers start going down and that we can get back to life as usual in the near future. We understand it may take many months, and we will feel better once a vaccine becomes available. Another more middle of the road response includes being an educator. My job and the way I interact with students, other teachers, and administrators has definitely changed. But I feel as if we're all handling it well and working through the changes for the betterment of our district. My concern with my children comes from not receiving ongoing medical care, such as baby checks, follow-up visits with specialists, and so on. And then finally, at the other end of the spectrum, we have people saying the following. We are worried. We feel going out is a gamble or lottery game with possibly deadly consequences. We worry anytime we have to leave the house. We worry the state is reopening too soon. And I'm an at-risk ER physician working in places I consider unsafe with inadequate ventilation and PPE. I have at-risk family members, one 19-year-old son with asthma and another working at the airport. I have elderly at-risk parents I'm concerned about. I currently just want to hide in my house. This is awful. Sometimes I just want to die rather than go on in this world. So I think that even just this sample of responses really highlights how critical this study is in terms of understanding individuals' responses to the pandemic. Ultimately, it's our hope that we're going to be able to take this data to inform what we as an institution need to be doing for our patients and for our patient family members, but also for our staff and for our volunteers. And that in the long run, this data can be used to inform community efforts to help support our community members. Thank you.